Well, good afternoon, good evening, colleagues in the field, and also colleagues in New York. Good morning. Hope you all have a very refreshing weekend and happy to join us for today's session. And we maybe got a bit different agenda today. Before we go directly to the lectures on cholera, I would like to make a tribute announcement. With great sadness, I'm here to inform you of the passing of Dr. Joseph Massey, who passed away last week on November 15th after very struggling months of medical management conditions. And most of you must have known Dr. Massey through the global webinars platforms. As you may know, Doctor is a professor of medicine in infectious diseases working at the Elmhurst Hospital Center in Queens, New York City. And he serves as the director of the Department of Medicine from 2002 through 2000. Also, he's a chairman of the Department of Global Health since 2017. He's also professor of environmental medicine and also global health at Mount Sinai. And Doctor has also co-authored many books and won over 10 awards and honors. And you can know more about him through the video clips and the wiki resource Alexandra is going to share in the chat box. So since 2019, as you may know, Dr. Massey has provided great guidance support for the UN medical workforce communities, doing more than 20 webinars for us on various infectious disease and related topics. And we all take good advantage of extensive experiences in evidence-based care for patients and clinical studies, providing us very invaluable knowledge and education to us, especially during the very challenging time of a pandemic. Dr. Massey was always so kind and open and humble for a man of his stature. And this was really a great honor and pleasure for all of us to work with him. And his passing is a great loss, definitely for all the UN medical community. So on behalf of Dr. Harari, the workforce management team and other DHMOSH teams, also our field colleagues, I would express sincere condolences to his family. And he will be greatly missed, and his endeavors and the legacies of global health and more will always and forever be in our hearts and inspiring us to strive forward. And today we also have the honor to have Leopoldo Silva Severo and the Deputy of Global Health in the hospital joining us. So now I will give the floor to Leopoldo to share some of her thoughts. Leopoldo, over to you.
Thank you very much. Good day, everyone. Thank you for sharing this platform with me this morning. I've had the honor to work with Dr. Massey for 24 years. I know he's more than a mentor to me and to everyone here. He's a friend, right? He's family. To have had the opportunity to work with greatness and to develop myself alongside him in all our global health endeavors, I can say he truly enjoyed all the work he did with everyone here in the United Nations and being on these global health seminars every Monday. He showed everyone that he worked with how to move through life with composure, with integrity, with humility, never letting anything disrupt, whether too good or too bad, always being the voice of calm and reason. I know that he showed all of us how to overcome challenges, how to face and guide us through this pandemic. He's been an inspiration to many people, but what I can attest to with working with him for so long is that he also felt very inspired by everyone he came across throughout the path and everyone he connected with along the way. He will forever be in our hearts because he shared all of his knowledge with us. So I know in each of us, we have some of Dr. Massey. He will continue to be part of our everyday fighting the good fight, moving forward, being of public service. He truly laid the path for us in a dignified way, truly the Massey way. I hope to still continue to be able to help in any which way we can here at Global Health at Elmhurst Hospital. You can always reach out to us. We are always accessible. It's one of the things that Dr. Massey has always showed us, to always be available when anyone is in need. And we look forward to always future collaborating with everyone here. Thank you very much for this time.
Thank you, Leopatra. Definitely, I think we will look forward to have more cooperation with you and also follow up the legacy by Dr. Massey. And
Absolutely.
colleagues, for your kind info, our team will assist and attend the tribute event honoring Dr. Massey scheduled on November 30th. So feel free to send us your condolences messages or to donate in honor of Dr. Massey to Elmhurst Auxiliary and Hope for the Healthy Community, Healthier Humanity Project. And Alexandra has just shared the links in the chat box. So feel free to click on the links also about the video introducing Doctor and also this donating website. Okay, so now we move to today's program, and based on the last week webinars, today's session is focused on cholera outbreaks in related regions and its prevention treatment. And the session will also be provided by Dr. Esther Tan and her team. And before we come to the briefings by her and also the consultant, I will also take some time to introduce Dr. Tan. It's a shame that even though most of you have known about her and she has been so dedicated to the support to the field guidance, but we never got a good chance to introduce her. Dr. Tan, currently her team, as you may know that, providing all the senior advice, the senior management on public health matters and implementation of the infectious diseases and disease prevention programs for the UN personnel globally. And during the pandemic, actually, Dr. Tan and her team is the first responder, actually has involved in the field assessment and providing all the good, this kind of support and recommendations to senior leadership in the emergency responses. And before joining the UN, Dr. Tan actually has been served as Epidemic Intelligence Services Officer in the US CDC and also in the Ministry of Health in Singapore as Assistant Director. And Dr. joined the UN in 2006, firstly with the DPKO, and has since held various positions, including working in Medical Director's Office and the Office of Special Envoy of the UN Secretary General on Ebola. And she graduated from University College London Medical School, qualified as a physician in 1998 and received Master of Public Health in Health Policies in 2003 from Harvard School of Public Health. She is also a published author of several scientific publications, including Clinical Infectious Diseases, Emerging Infectious Disease, and Journal of American Medical Associations. So we are very happy and really appreciate the support by Dr. Tan and her team. So now I will give the floor to Dr. and also introduce about topic and her two consultants. Esther, over to you.
Yeah, Esther's not here today from my understanding.
Okay, in that case, I think, yeah. Okay, I think Esther, oh yeah, I just see her note. But in that case, let me introduce Dr. Devika. Thank you, Devika.
Sorry, let me just interrupt you. Today is her birthday, so everybody can send out like birthday greetings. So she will not be attending today. Thanks.
Okay, so Fola, you would like to introduce our consultant?
Yeah, I can do that if you want me to do that.
That's great.
So good morning, colleagues, and good afternoon, wherever you're located. Thanks for having us this morning. As you know, I mean, in many of our field locations now, we've been dealing with cases of acute watery diarrhea And some of our missions are actually dealing with active cholera outbreaks now. And so we find it so important for us to bring this topic and talk to our colleagues wherever they are, because we've been supporting different locations technically on how to respond to the cholera outbreak. So this morning, it will be, all the talk will be about cholera and how to prevent it, and the vaccines and the clinical management. So I won't talk so much on this because we have two of our colleagues who will be talking to us on this. I have one of our colleagues, Jamie and Jablonski, and then Dr. Devika Dixit. So both of them will be doing the presentation together. So over to you guys.
Okay, thanks, Fola. So the way that this presentation is going to be divided is I'm going to start with an introduction and then talk about the clinical management, and then Jamie will talk about the rest just because I have to get going in about 20 minutes. So as Dr. Fola mentioned, this talk is on the outbreak response to cholera, and we'll touch on a bunch of different topics. Next slide, please. So just talking about the outline for the presentation, as I mentioned, I will touch on the introduction as well as the case management for cholera within the treatment facilities. And then we will move on to outbreak detection, outbreak management, how to make the diagnosis of cholera, cholera vaccine, and then how we monitor an outbreak. The other key parts of an outbreak response, including risk communications, as well as how to reduce the spread of cholera in the community, will also be discussed. And just to note that if people are not familiar with the Global Task Force on Cholera Control, a lot of the information from this presentation will come from that field manual, and please take a look at it if you're not familiar with it. Next slide. So just briefly about cholera. So this is a bacterial infection caused by the organism Vibrio cholerae. And there's two types. There's O1 and O139. And as we know, this causes an acute diarrheal syndrome, basically because the intestine is getting infected with this bacteria. You need about 10 to 5 to 10 to the 8 of this bacteria to become infected. And when people have diarrhea, this bloody diarrhea, they have 10 to the 11 to 10 to the 12 bacterium in the rice water stools that they get. Both children and adults can be infected. And about 20% of those that are infected are going to have the acute watery diarrhea, this rice water stools that we typically hear about and see clinically. And then 20% of these individuals are going to develop severe watery diarrhea. Many of these are going to have other abdominal symptoms, including vomiting. And so this group, this 20% that has a severe watery diarrhea, this is a critical group, and we'll talk about that a little bit more in the next slides. So the key to management of cholera, the absolute key, and if you're going to remember one thing, it's that when you have severe dehydration, you will have death occurring within hours if you do not replace the fluids as well as the salts. So that is the one critical point of this entire presentation. If you do not treat, the case fatality can be up to 30 to 50%. However, if you do the treatment, which the mainstay is rehydration, that case fatality rate should really stay below 1%. So again, just really highlighting the importance of hydration for cholera patients. Next slide, please. So I'm going to have two slides here about the common sources of cholera within the community, but the key point of both of these slides, this slide and the next slide, is that cholera is transmitted by the fecal oral route. So that is a key principle within cholera, but of course, the way that then this is spread is through all the contamination of water and food, for example. So some examples here, I won't go through all of them on this slide and the next, but just keep in mind that the principle remains the same. But basically you can get fecal contamination of the drinking water or storage water or your water supply. If you've got uncooked food that was then washed with contaminated water, drinks, ice cubes, and others, that can be another source of contamination. And then even the utensils that you're using, if they're washed with contaminated water, they can be a source of infection. Next slide. So this slide then goes into more detail about the same types of things that I talked about. So whether the food is being prepared and cooked and then left out at room temperature for several hours, then you can get that growth of that bacteria within the food. Some specific foods like the seafood, shellfish, and others, if you eat that raw, again, this is a fecal oral contamination within the seafood, that can be a problem. Other foods like fruits and vegetables can also get contaminated through the washing process. And really, in general, that's the kind of key of how you get infected. It is important to note that household members and close contacts of cholera patients are at high risk. So about 50% of household contacts are going to develop this infection within 2 days of somebody in the household having the infection. So that's really important. Next slide. So we're going to, as I mentioned, we're going to touch on diagnosis and some of the other kind of outbreak management pieces after I'm finished this part. But we're going to talk about case management in the healthcare, or sorry, in treatment facilities as well as at home, just because it's an important part of management. As I mentioned, if you're dehydrated and you're severely dehydrated, that is the #1 predictor for mortality. So the key really is that there are, and we're going to go through this in another slide in a minute, but you've got patients that have different levels of dehydration. So they can have no dehydration, some signs of dehydration, or severe dehydration. And depending on the level of the hydration, it's going to affect whether or not you're going to be hydrating with oral solution or with IV solution, and if you're going to be treating them at home or in a treatment facility. So that's kind of the overview here, and I will go into more details on the next slides. So I think I talked about this already, but approximately 20% of individuals are going to develop the severe diarrhea. So this is really the group that we want to be focusing our management on. Of course, all of them need management, but this is the most critical group. And when we talk about severity of illness, it's really related to the number of bacterium that we have ingested. I talked about how you need 10 to the 5 to 10 to the 8 in order to actually get infected. If you have lack of immunity because you haven't had a past infection or you haven't been vaccinated, lack of breastfeeding in younger children, malnutrition, an immune compromised state, as well as the reduced ability to produce gastric acid, as well as blood group O. These are all risk factors for severe illness. Next slide. So the next few slides, I'm going to just talk about the assessment and triage of the patient, as well as some data collection forms that can be used when we're seeing patients. And so as I've talked about, we have our 3 groups. So the no hydration, some hydration, and severe hydration. And depending on which group you fall into, as I mentioned, these are where you're going to have the different action plans. So in summary, the no dehydration is an individual who's awake and alert. They have a normal pulse. They're thirsty in a normal way. Their eyes aren't sunken, and their skin turgor, the skin pinch, is normal. In those individuals, you're not typically admitting them to any treatment unit. They're managed as an outpatient, and they're going to get oral hydration therapy. If you have some dehydration, this is a critical group because they could go either way. So if you don't get on top of their hydration, they're going to potentially go into the severe dehydration category. So they don't have danger signs, but they do have other features, including irritability and restlessness, the sunken eyes, rapid pulse, thirst, but increased thirst, and then the skin pinch, the skin turgor there goes back to normal slowly. Now, these individuals are typically admitted to the treatment unit, but they're usually hydrated with oral therapy, and I'll talk about that more in the following slides. And then the severe dehydration. So these are individuals where we're kind of like, now we've missed the boat here. We need to really aggressively hydrate these individuals. These people can be lethargic or unconscious, absent or weak pulse and respiratory distress, or they might have at least two of the following. So the sunken eyes and not have the ability to hydrate themselves. And the skin pinch takes over 2 seconds to go back to normal. And these individuals have to be hydrated via IV. So this is just kind of a summary, and then we'll go into a little bit more detail in the next slides. So this slide and the next slide, it just is basically like a template to keep track of patients while they're in the treatment facilities. So it has their identifying data, their clinical data. So you can see here how many stools they're having, vomiting, because this is really a marker of the output that you have. And then we've talked about on the physical exam, these danger signs, and then what actions to do. And as you can see, these are color coded in the red, yellow, and green. And so the red is obviously the danger signs and where you need to really be quite aggressive. Next slide. So this is the same, this is just the second part of that, and it goes into the details of what kind of volumes of fluid you need to give and how frequently, and they divide it up based on age as well. And so when you have these templates, if you're dealing with a cholera outbreak in a treatment facility or others, it helps you to systematically get the information as well as triage the patients appropriately. So this is just here for your reference in these 2 slides, and this is also available on the Global Cholera Task Force website shown below. Next slide. So I'm just going to provide a little bit more detail into the 3 groups. So the no signs of dehydration, some signs of dehydration, and severe dehydration. So we've talked about this a little bit, and every time I'm building a little bit more information into the slides. So for the no signs of dehydration, as I mentioned, these individuals are treated with oral rehydration. And typically, this is going to be done at home. And then in some instances, you can do this in the oral rehydration points. So sometimes there's outpatient points set up for rehydration, as well as potentially in an outpatient area. But the key is that this is outpatient management when you have no signs of dehydration. If you are moving to the point where you're having them at a oral rehydration point or in the outpatient area, then you typically want to observe these individuals for at least 2 to 4 hours, because you want to make sure that they're able to
charge about how much?
We just want to, I
I'm
think
arriving at about
Colleagues,
1
please
a.m.
unmute
When I
it from
see
your
the
end.
tax,
Thank you.
so you want to observe these individuals for at least 2 to 4 hours to ensure that they're actually tolerating the fluid, because that's what they're going to do when they go home. Then you're going to provide them with instructions on how to administer the oral rehydration. And basically what you're going to do is after each loose stool, you're going to give them, they're going to take oral rehydration. And then of course you want to advise them about when to return if things are getting worse. So the key is that you're really replacing the fluid every time you are having a stool, and for mild cases, so the ones with no signs of dehydration, it's oral therapy, not IV, and it's done in the outpatient setting. Next slide, please. So then for the oral hydration for individuals that have some dehydration, so remember we talked about those signs in the previous slide, these individuals do get admitted to the cholera treatment centers because they are at risk of going into severe dehydration if they continue to have the stools at high volumes. So the initial hydration therapy for these individuals is that you're giving a 75 milliliter per kilo oral rehydration in the first 4 hours, and then you continue to replace as per the stool losses. And this table here This is applicable for all of the for the ones that have no dehydration, and then individuals that have some dehydration. And it just kind of gives you a sense of how much oral rehydration solution needs to be given when you're having each stool. So if you're having one stool, as we said, we want to replace the volume, but this just gives you a little bit more detail into the quantity that you want to give. Next slide. So, so this is just another key, that those that are presenting with some signs of dehydration do not need IV therapy. They need the oral therapy, and they need to be monitored. And of course, if you're going into a situation where they're not able to tolerate the oral therapy because they're not able to drink for whatever reason, or they're actually having vomiting, then of course this is another reason to use IV therapy. But in general, you want to give oral therapy for these individuals. They're going to be continuously reassessed kind of every 4 hours to make sure that they're still falling within this moderate category. And if they eventually move to the no dehydration, then they can be managed differently. But if they move into the severe dehydration, which we're hoping isn't the case, given that we're trying to hydrate them, that they should be able to do okay. Next slide. So then this is again the critical group that I've mentioned a few times now. So these are the individuals with severe dehydration, and these are so critical because the longer you wait to manage these individuals, the worse it's going to be. So you want to have quick action. So these are the individuals that are getting IV fluids, and really the goal is to give IV fluids for as long as necessary, but to switch to oral rehydration as soon as we can. And the key fluid that is used in general is Ringer's lactate. So that's the fluid of choice, just given the concentration of the electrolytes, so the salts in that fluid, that is the fluid of choice for rehydration. However, if that is not available, there are some alternatives that can be used, but really the bottom line is, for the key point, as mentioned on the slide here, is that you really want to use Ringer's lactate via IV. When you're giving the fluid, you're trying to give a goal of 100 milligrams per kilogram of Ringer's lactate divided in 2 periods. Next slide. So I've spent so much time talking about hydration because that is what is going to affect mortality. It's the hydration. But of course, there is an additional management because Vibrio cholerae is a bacteria. We are going to be also using antibiotics in a certain group. And so antibiotics are not given for all individuals with cholera, but they are given for hospitalized patients, so the ones that are in the treatment units with severe dehydration. And so that is really key because it's not for every person. It's not for the contacts. It's not for the individuals that have no dehydration or some dehydration. It's for those that are severe. And so again, this is just giving you a sense of those that have high purging individuals who are actually not getting better with hydration therapy alone and are still dehydrated, even if they're actually not as dehydrated. That's a second group that it can be considered in, though the first group is really the mainstay where we treat. And then in some individuals that have some pre-existing conditions such as pregnancy, severe acute malnutrition, HIV, and others, those individuals are ones that you might want to consider treatment in, even if they're not severely dehydrated. But in general, that's the main group that you're going to be giving the treatment in. So for antibiotic choice, the first line is doxycycline. And doxycycline, as people know, is not typically a drug that's used in pregnancy or in children. Typically, this is changed typically under 8. But in general, we're still going to give a single dose of doxycycline regardless. So we're going to give that in the groups of pregnant women and children as long as they're severely dehydrated or have some of these other risk factors. In a situation where you have a Vibrio cholerae that is resistant to doxycycline, then alternatives include azithromycin or ciprofloxacin. But the drug of choice, and when we're doing treatment campaigns for cholera, we're usually using doxycycline. Just a key is that we're not going to be giving mass drug administration. So again, we're not treating all the contacts, we're not treating everyone, but we are treating those that meet these risk groups. Next slide. So specifically for children aged 6 months to 5 years with acute watery diarrhea, there is evidence that zinc supplementation in these children is beneficial. And so there is a recommendation that when you have a child presenting in this way, that we give 20 milligrams of zinc sulfate every day for 10 days, and that should be started immediately. Now, it is important to note that zinc can affect the absorption of some antibiotics, including ciprofloxacin. And we talked about how ciprofloxacin isn't going to be your first line drug, but doxycycline is. And in order to just make sure that you're not having issues with the drug interaction, you just want to make sure that the antibiotics are administered 2 hours before zinc or 4 to 6 hours after the zinc. And as you remember, it's only a single dose of antibiotics that we're giving anyway. So this really shouldn't be a long-term implementation issue, but it's just something to be aware of when you're giving that dose. It's also important to note that children that are receiving food therapy as part of their severe acute malnutrition do not require additional zinc supplementation because the food is already containing sufficient zinc. Next slide. So it's just obviously important to be aware of complications. So we've obviously talked about if you're not managing appropriately, the number one and feared complication would be death, but others include individuals, so the children with the severe acute malnutrition, the elderly, as well as those with uncontrolled chronic conditions, they're vulnerable to complications. And some of these complications include things like pulmonary edema, if we're too aggressive in our rehydration. So of course we have to rehydrate, but we have to hydrate appropriately. And that's why there's volumes given in those sheets that are important to keep an eye on. You don't want to over rehydrate. And then you have issues with renal failure, acute kidney injury if you're not hydrating fast enough, and then the derangements of the glucose as well as the potassium that can both be low, particularly with children, and especially those with malnutrition. Next slide. So I kind of touched on this, but the goal is obviously to be able to discharge the individuals from the cholera treatment center. And while we have them in their different categories, following their different plans, eventually the goal is to have them discharged. And you're going to discharge a patient when they no longer have signs of dehydration. So that's the no signs of dehydration. They're able to take the oral rehydration solution and they're not vomiting. They have not had any watery stools for 4 hours, are passing urine, and then are able to ambulate out. And as you probably know from those that have had experience with patients with cholera, when they're severely dehydrated and in that acute phase of illness, they cannot move, they're prostrate. And so we just need to be aware that all of these things need to be taken into consideration when we're thinking about discharge, like we do for a lot of other medical conditions. Next slide. So I'm going to pass on the presentation now to Jamie, and she's going to go through the outbreak management and others, and I will have to step off, but Dr. Fola and Jamie will stay on the call just to answer the questions, and thanks everybody for your time.
Thank you, Dr. Dixit. So I'm going to go over, my name is Jamie Jablanowski. I'm a public health nurse consultant with DHMOSH. I'm going to talk a little bit about outbreak detection, managing an outbreak, reducing the risk of spread, a little bit about the oral vaccine, and then a little bit about more just infection control practices. So starting with just some basic definition, the definition of acute watery diarrhea is 3 or more loose stools within a 24-hour period. A suspected cholera case in areas where a cholera outbreak has not yet been declared, any person age 2 or older presenting with acute watery diarrhea and severe hydration or dying from acute watery diarrhea. And in areas where a cholera outbreak has been declared, any person presenting or dying from acute watery diarrhea. A confirmed cholera case is going to be any suspect case of E. cholerae 01 or 0139 confirmed by culture or by PCR. So those two are the gold standards for confirmation. A cholera outbreak is defined by the occurrence of at least one confirmed case of cholera and evidence of local transmission. So in terms of laboratory confirmation, when an outbreak is suspected and alert is triggered, you want to collect stool from the sample. You can use a RDT or a rapid diagnostic test, but you really want to make sure it's confirmed by stool culture or PCR, but you don't want to delay treatment of dehydration in the patient. Just also as a reminder that specimens should be at ambient temperature at all times, and not to refrigerate the specimens, as refrigeration can decrease the population of the bacteria in the sample. In terms of organizing the response and case management, you want to, and some of these things are going to be pertinent to your clinic. Some of these may be happening on a wider community level or even national level. So these are just the overarching principles and may kind of change depending on what level you're working at. But you want to immediately set up oral rehydration points. You want to ensure staff are trained on the treatment protocols. You want to, project this information to anybody who may be involved in treatment. You want to make sure you have adequate supplies and education material, job aids are in place. You want to ensure that these oral rehydration points and CTUs are accessible to the most affected population. So be strategic in where you're placing these specific points. You want to work closely with your epidemiology and logistics teams to predict supply needs, be in contact with DHMOSH if you need support. You want to train healthcare workers on the use of RDTs, of diagnostic testing, specimen collection, and transport procedures. Know what your laboratory needs and how to transport samples to the laboratory. And then work closely with your water and sanitation and hygiene and logistics colleagues to ensure adequate infection prevention. So, before we want to work, while we're working to do a clinical management of a patient, we all want to make sure we're preventing future cases from happening and focus on the prevention piece as well. Key actions to reduce mortality, Dr. Dixit mentioned this, is really distributing, is focusing on that dehydration piece, because death can occur so quickly. And so that's oral rehydration salts in the community and to households. You want to explain how these work and how to administer them. You want to employ early detection and triage and transfer of severe cases for IV fluid and treatment. If you're working in a clinic, this is something you can even start thinking about before your first case comes in. How are we going to educate our staff on what to do, what the first step to do is, where to come for triage, and how we're going to take cases or refer cases to local hospitals and acute care centers. You want to train health professionals using standard case management protocols, IPC measures. Those Dr. Dixit went over a lot of those treatment protocols and forms. So you want to make sure that those are on hand, ready to go, and you can easily distribute with your colleagues. You want to estimate and take count of your supplies. I think this is also something, if you anticipate early anticipation of potentially seeing a cholera patient, is making sure you have the supplies on hand to treat, the population that you have. And then you want to inform the public. And so this, again, these are overarching principles, but you want to inform, the people in the community that you're working with and your staff, that what you should do if someone does experience diarrhea. Who should they call? Email blasts, using the resources at your disposal. You want to identify possible sources of contamination and main transmission. Again, this may be happening at a community or nationwide level. Might be other teams kind of working on the water management, but also if you know that certain areas may be contaminated, making sure you're sharing this with personnel and staff. You want to provide safe water in sufficient quantities, improve sanitation. You want to monitor your water sources for free chlorine levels and report any gaps. Again, this may be happening in different teams responsible than the clinical management team. But overall, the main goal is to strengthen these IPC measures and make sure that there's access to clean water to prevent further spread. You want to communicate often to staff and to personnel through, again, what means if your staff doesn't normally answer email, then maybe social media is more effective, maybe email is most effective, maybe having a webinar is most effective. So you want to think historically what's been most helpful for the community that you serve and the patients that you serve, and then really use that as your main means of communication. You want to include the oral cholera vaccine as part of the multisectoral interventions to cholera. But again, if you start seeing cases, the focus on the dehydration and treating and the oral rehydration is very important. Touching on the oral cholera vaccine, WHO recommends that the use of the vaccine should be considered as an additional measure to limit the spread of disease during cholera outbreaks, to contribute to cholera control in high risk and endemic areas. It should be used again in conjunction with other cholera prevention strategies. So we really want to make sure that we're cutting off exposure and contaminated water at the source, in addition to using the oral cholera vaccine. And then just to touch that the use of the vaccine in pregnant and lactating and HIV women is recommended. There are considerable benefits and very few risks from including pregnant and lactating women and HIV infected individuals in a vaccine campaign, so they should not be excluded. In regards to monitoring an outbreak, and it's a lot of information, so I'm just going to touch on it. This is all of the information in this PowerPoint. You'll have the slides, but it's also included in the Global Task Force on Cholera Control, that field manual that's linked early in the presentation and also at the end. But when you're making a line list, you want to keep track of any suspect or confirmed cases. You want to make sure that you're keeping a line list, and you can download these materials from the website that's provided, gtfcc.org. But making sure you're including all of this information here on the right, and it's in the appendix, to make sure that when you're putting together your cases, you're keeping organized and you have this nice line list to kind of see, who's been infected, when, the age, and start to put together a picture as quickly as you can. These are some additional resources in regards to risk communication and community engagement. They're all linked in the presentation, and they're all included in the field manual for further reference. These are talking about key messages for health education. You want to focus on what cholera is, how it's spread, how to protect yourself, your community, your family. You want to really focus on educating about personal hygiene, washing your hands, washing hands with cooking, before eating, after using the bathroom, when taking care of a sick person. If you have to do a hand washing demonstration, we talk about this pretty much with every infectious disease, but just making sure people know how to thoroughly wash their hands. They're washing for long enough. They're not missing the areas. I talk a lot about people often miss back here, under their rings, in between the webs of their fingers, and keeping their home and latrines and toilet facilities clean. Cooking and preparing food, again, it's spread through fecal oral route. So cooking raw food thoroughly. Dr. Dixit went over, many of these different methods of transmission, but just highlighting these to the population that you're serving about, healthy cooking and safe food preparation and safe drinking water. Safe food preparation, just to touch on it again, just making sure that, I think these graphics can be really helpful as a reminder about different safe food preparation methods. And again, this can be something that can be delivered and part of your education and part of your outreach. So if you're using social media or email blasts, this can provide nice reminders. Remember to, do X, Y, and Z when cooking or preparing food. So these are 15 rules also included in the appendix. This can be shared with your community, with your patients, with staff. That you should cook raw foods thoroughly, as Dr. Dixit mentioned. Fish, shellfish, and vegetables are often contaminated. They're your more high-risk foods. You want to eat cooked foods immediately, cook to proper temperatures, making sure you're washing your food with clean water, washing your hands, keeping surfaces clean, and using safe water to cook and prepare your meals. And as Dr. Dixit said, even the utensils, if they're not washed in clean water, could potentially transmit the bacteria. And access to safe drinking water is essential. So if you can provide drinking stations of clean water to the population that you serve, that's very helpful. Or maybe if their information is sent out about where clean water can be found, that can be helpful to send out that information. In this Appendix 3, and we're going to touch on this in a second, but there's methods of how to disinfect the clean water through boiling, through chemicals, and that's all included in this appendix, which can be shared. You want to educate on what to do if a family member is ill. Dr. Dixit mentioned how quickly it can spread between families. And so the biggest danger is fluid loss from the body. And you want to, really encourage people not to delay treatment, that not to panic. You don't want to, incite fear, but you do want to encourage patients who are experiencing diarrhea to act quite quickly, especially obtaining oral rehydration salts. If they already have them on hand, that's great. And then making sure that you're using safe boiled or chlorinated water to mix those preparations. You want to go immediately to a community health worker or health center, and they should continue to drink the oral rehydration salts while seeking care. And you also want to encourage the continuation of breastfeeding while a child or mother has cholera. When taking care of sick people, again, standard infection control practices apply. You don't want to wash a sick person's bedding or clothing in a water source. So you don't want to, if you have an area of clean water, you don't want to use this water to clean potentially contaminated clothing. You want to avoid direct contact with stool and vomit. And you want to disinfect the person's clothing and bedding with a solution of chlorine, 0.2%. If the chlorine is not available, this person's bedding and clothing can be disinfected by stirring for 5 minutes in boiling water and drying in direct sunlight, or by washing with soap and drying thoroughly in direct sunlight. So I think this can be really helpful information if you have staff that have family members that may be sick, or they want to know what to do, what if, to kind of share this information as soon as you can. This is, again, kind of different ways to provide water treatment through boiling, chemical disinfection, solar disinfection, and it kind of gives you a nice guideline of how to perform each one of these methods of treating the water. This is kind of a nice, I like this graphic. It's kind of a nice overview of kind of all the different ways we can approach cholera. So we have antibiotics. It shouldn't be mass treatment with antibiotics to everybody, but as Dr. Dixit mentioned, it is appropriate for hospitalized cases. We have cholera beds, cleaning equipment, oral rehydration salts, plastic sheeting, catheters and IV fluids for those who need it with moderate severe dehydration, chlorine, and then protective clothes. I want to touch on this, that the standard PPE for treating cholera patients is just a gown and gloves. And then again, hand washing and standard precautions always apply. So these are the resources. We have this Global Task Force on Cholera Control manual. Highly recommend looking through it. It's quite extensive. The appendices are great. They have a lot of information that can be shared. And then we also have the UN Medical Director's Risk Mitigation Plan. And I've also linked that here as well, that you can use to kind of have a checklist and see what you need to do in preparation or treatment of cholera in your community. So thank you very much.
Thank you, Jamie, for the kind presentation, and also Devika has left, right? Okay, I see that, Paula, thank you so much. I see you have provided some feedback in response to the questions from our colleagues in the chat box.
Yeah, yes, I started providing responses to some of the questions in the chat box. Somebody just asked now that the cholera vaccines, that they don't currently have vaccines in the Gambia, and that what about if they have an outbreak? So what we have been telling colleagues is, if you have an outbreak, just you can inform us, and then we can coordinate with the MSS to see how they can support you to order the vaccines. And you see, most of the time, the cholera vaccines are not really available in the market, because most of the vaccines are held in the cholera global stockpiles that are being controlled basically by the task force and WHO. But some countries can still be procured from different manufacturers. Yeah, thanks.
Okay, and I noticed several colleagues are asking about what is the current outbreak mostly in which region, and would you just reconfirm the countries and the regions?
Well, we have some countries that are having current active outbreak of cholera. Syria is one of them, Malawi is one of them, and then Haiti is one of them. And so, as you know, this is an evolving thing. It can pop up in any part of the world. And so what we normally tell our colleagues is, anytime you have any outbreak within your country, you don't need to wait until when you have it among any UN personnel. Just let us know. Some of those countries, they notify us, and we provided some technical support to them on how to respond. We provided them the cholera risk mitigation plan that was developed by the UNMD, And also, some of them we've been successful in helping them to secure some of the cholera vaccines for use among UN personnel. And also, we also supported some of the country to get the aqua taps, the chlorine taps for water purifications. So those are some of the things that we can actually leverage at our level, but we can only support if you notify us on time. Yeah, thanks.
Okay, thank you. Let's see, any other questions? Also from our colleagues in Lebanon, and asking about how much cholera oral vaccine can provide protection.
Yeah, this basically depends on the, actually I responded to this. This basically depends on the type of vaccine, the type of oral cholera vaccines that you are using and the manufacturer specification. The WHO has pre-qualified only two, which is Equivoco and Sancor. Those are the ones that have been pre-qualified by WHO. And those two, the doses that you get is, you get the first dose and you get the second dose 2 weeks later after the first dose. That is the manufacturer recommendation, because the two vaccines, basically they have the same chemical composition. And that is what WHO has pre-qualified for use for now. And that is what, if we are helping you to get vaccines, that is what we will be sending to you. And in the global stockpile that has been used by WHO to support country level cholera outbreak, and those are the two vaccines that have been used also. Yeah. So it all depends on the vaccines that we are using and the manufacturer's specification on the dosing. Yeah.
Okay. Yeah, colleagues, as Fola has said, currently we are also following up closely about outbreaks. And if you got any latest this kind of data or this kind of pictures about the on the ground, so feel free to keep our public health team in the picture so that we can also update the figures and broadcast the whole picture about the outbreak.
Yeah, Dr. Nilankan also added a comment on the chart,
Yeah.
which is actually valid. The strain in an outbreak may not be the same as the vaccine that are currently available. So that is another thing that you need to look into before. It's not that, oh, you just need to come up and start loading people with the vaccines. So those are some of the things that we are normally consider and check with WHO also before supporting anybody with the vaccines.
Okay. So colleagues, do you have some other questions? You can also unmute from your end.
While we are waiting, if there are any other questions, what I want to tell us is this: we have a cholera dedicated web page, which is on the UNHR portal. So on this particular web page, you can access all the resources that we have developed. Some of them are developed in conjunction with the UN medical directors, and also some WHO links that are very helpful to coordinate your response. Instead for you to be scattering, oh, we have a cholera outbreak, what do I need to do? Which site do I need to go to? Just go to the HR portal, go on the cholera page itself. It's like we pull all the necessary resources together for you on one page that you can use. And you know, some of the things like, oh, any UN personnel, when they are affected, what do I do? Check the risk mitigation plan. Some of those things are actually itemized on the risk mitigation plans. Yeah, thank you.
Dr. Fola, I just want to share that I just shared the link in the chat. So anyone who wants to go directly to the UN webpage, it's in the chat.
Okay, thanks.
Thank you, Jimmy. Thank you, Fola. So I think Alexander, we still have Kahoot.
Yes, we have it. I'm ready
Okay,
to share it
so-
if you like.
Oh, that's great.
Okay, one moment.
Thank you.
Just to also to add, while we're waiting for the Kahoot, we'll be sending the, Rui and the team will be sending the presentation to everybody so that they can have a copy of it also. Thanks.
Yeah. So colleagues, get ready to join our games. 0. Beautiful, colleagues. We need 5 more to start the game. Thank you. Okay, Alexander, we can start.
If it's helpful, I can read the question.
Definitely, yeah.
Okay. Okay, so our first question, what percentage represents the case fatality rate in untreated cholera cases?
That's a sodium.
You can also type in the chat box.
So the answer is C, 30 to 50%. And I saw a lot of B's come in, the 20 to 30%. So I think it can be alarming how high the case fatality rate can be. And I just wanted to, I chose this question to emphasize how important treatment is.
Next, yeah, okay. Great, Max.
So our next question, when treatment for cholera is provided, so what is the case fatality rate when treatment is provided rapidly? Okay, great. So mostly everyone got this correct. It's less than 1%. And, I had these questions back to back to show how important rapid treatment is for patients that are presenting with suspect or confirmed cholera, because the case fatality rate drops to less than 1%, which is a significant difference. Next question. So adult patients that present with no signs of dehydration, what should be the first treatment of choice, the primary treatment? And we have antibiotic therapy, oral rehydration salts, IV fluid, or zinc. Okay, great. So it's oral rehydration salts with no signs of dehydration. I think this is important to, emphasize, especially if they have the sachets of the oral rehydration salts at home, to make sure that we're educating that, if at the first signs of diarrhea or first symptoms of cholera, suspected cholera, that you're appropriately mixing and using the oral rehydration salts. And our next question, what is the first choice of IV fluid for treatment of severe hydration in patients diagnosed with cholera? So this is when you have severe hydration and treatment has moved and progressed to IV fluids. Dr. Dixit went over kind of the different options, but here we're going to focus on what is the first choice. Great. And so the answer is Ringer's lactate. And it looks like Matt is still in the lead. So great job, Matt. Here, yeah, it's final question to see if you can stay in the lead. Which poses the highest risk for cholera? And this is the food sources that we talked about. Crab, canned potatoes, almonds, or packaged cereal. And it looks like most people got this correct as well. And it's crab. So any type of shellfish, all food and preparation and prepared food is at risk if you're hand preparing it, because cholera spread through the fecal oral route. But crab, especially, in any kind of shellfish, you want to make sure that any crustacean, crab, shrimp, is cooked thoroughly before eating, because shellfish can be a high risk food. Canned potatoes, they're pasteurized before, they're cooked and preserved before. They're less of a risk. Dried fruits and nuts are less of a risk. And packaged cereal, again, this is stayed in vacuum sealed packaging, but if you're eating it with unwashed hands, that's a different level of risk. But shellfish is one of the more higher risk foods. So we'll see if Matt stayed in the lead.
Okay, colleagues, let's see. Should be Matt. Good job. Thank you, colleagues. Congratulations to Matt. Okay, thank you, Jimmy and Devika, and also Fola for a very informative presentations and also all the key takeaway messages. I'm sure that my colleagues in the field find it very rewarding and informative. So colleagues, feel free to contact us and also the public health team to update the situation on the ground. And as always, we will always stand by to provide support to you this end. So thank you, and have a nice Monday and also a whole week ahead. Thank you.
Thank you.
Bye.
Thank you.
Thank you.
Thank you so much.